Here is Dr. Tittu Oommen, sir. He is a consultant endocrinologist in Providence Endocrine and Diabetes Specialty Center, Trivandrum. And he has many publications and in his name. Welcome, Tittu Oommen, sir, for delivering his speech.
Thanks also for kindly introducing me. So today's agenda is very simple. Why we have gone away from the name of NAFLD to MASLD, the clinical features and investigations and management of MASLD with respect to type 2 diabetes. So why the shift? So what has happened is that earlier in NASH was recognized in the early 1980s by Dr. Ludwig, and then later on by 1983 they had coined the term NAFLD. So what prompted the change is when they said non-alcoholic fatty liver disease, it was a sort of exclusion. So if you don't have alcoholism as a history, so there was no significant suggestion also what could be quantifiable as an alcoholic or not an alcoholic. And so that's kind of a diagnosis of exclusion. And also there were a host of other metabolic parameters that had to be included. So later in the early 2000s, in the late 2010 and all, they had a Delphi meeting, a consensus kind of meeting where they gave gastroenterologists, endocrinologists and people practicing diabetes and hepatology to ask for what are the relevant questions, and they found out that you have to have an inclusive criteria, not an exclusive criteria. And also the name was initially thought of as MAFLD, Metabolism Associated Fatty Liver Disease. Then again that term of fatty liver was not favorable because many people describe fatty as something to be only related to obesity, where a fatty liver can occur without obesity also. So with all these points, by in 2023 a consensus opinion was reached that, and simultaneously the term steatotic liver disease had attained very popularity, and a classification of steatotic liver disease came. So in the steatotic liver disease, there is clearly something known as MASLD, or metabolic dysfunction associated steatotic liver disease. Now here metabolic dysfunction is a core driver rather than excluding alcoholic use, and this is more sensitive for diagnosing liver disease in people with metabolic risk factors. So basically what has changed is you now have clear-cut criteria for diagnosing MASLD, and the next one, diagnosing alcoholic liver disease, almost it is similar as the decades ago, and other causes of steatotic liver disease is also the same. But these two things have come up, MASLD and metabolic ALD, metabolism MASLD associated with increased alcohol intake. So when you say MASLD, you are excluding, or you are not excluding actually, the alcohol intake is not sufficient to cause a steatotic liver disease or an alcoholic liver disease, and that would amount to a person with features of steatosis with one or more of the cardiometabolic risk factors like prediabetes or obesity, overweight or obesity, dyslipidemia or on antistatins, hypertension, or BP lowering medications. In addition to that, there are some people who will have MASLD, but their alcohol intake is not so low, but not as high as an alcoholic liver disease, and they are called MASLD with increased alcoholic intake. And MASLD with the increased alcohol means 20 grams per day in women, 20 to 50 grams per day in women, and 30 to 60 grams per day. So basically when a woman takes less than 20 or a man takes less than 30 grams of alcohol in a day, that means they fall into the category of MASLD. And when a woman takes more than 50 and when a man takes more than 60 grams of alcohol in a day, they fall into the category of ALD, alcoholic liver disease. So when it falls in between, it is MASLD with increased alcoholic. And whatever I am going to speak about today, the treatment, the reversal, the characteristics, all is about MASLD. The part what is happening to MET ALD is not very clear because it's a combination. Maybe these things would be effective in them, but it's not very clear. We need more data also. Why we have to speak so much and so about? Across board, the epidemiology with obesity and diabetes is increasing. This also roughly the prevalence is 55.5%, and in India also, Southeast Asia, you can see that 57%. So among people with obesity and diabetes, at least half will have some features of steatotic liver disease. you have to understand, even in people with pre-diabetes. Adults with pre-diabetes and type 2 diabetes have higher risk of developing steatotic liver disease. Now, when they get this liver disease, they have a chance of developing severe liver disease. In the Western world, in US, now this is the leading cause of liver transplantation. And when you have MASLD, you have higher risk of developing cardiovascular disease and other comorbidities. And the importance of early diagnosis is that at the level of MASLD, without advanced fibrosis, this is reversible. So equate something like that of microalbuminuria. So if you do a urine albumin creatinine ratio, you catch at a milder albumin excretion, you start on drugs like SGLT2 inhibitors or GLP-1 receptor agonist or the mineral corticoid receptor agonist like finerenone, you can reverse it. Same way, if you capture MASLD, if you screen for MASLD, you can reverse it. And there is a bidirectional relationship between diabetes and MASLD, the fatty liver disease. That is, when you have diabetes, 2.5 times risk of developing this fatty liver disease. When you have fatty liver disease, you have more than 2 times chance of developing diabetes. And both increases the risk of developing CVD. You all know that people with diabetes don't die of diabetes itself, they die of cardiovascular disease. So a simple diabetes alone or with MASLD has a higher risk of, the person with diabetes alone, a person with diabetes and MAFLD or MASLD, whatever be the terminology, has higher risk of developing CVD. So this is why this is more important in this current era. The right picture everybody will know from their Davidson days or the clinical Hutchison days, where it's the pathognomonic stigmata of CLD. That will not be seen in your patient with MASLD. Your hope is that your patient will not look like the picture on the right in a year's time. We plan to reverse it. There are absolutely majority of your patients no symptoms. Fatigue is one of the main symptoms. There can be a stretching of the liver capsule and cause a sharp or dull aching right hypochondrial pain. But all the signs and symptoms actually develop when the patient develops chronic liver disease. And your hope is to pick up them before that. So you have to screen. LFT can be completely normal on investigating, but mostly there will be mild transaminases, usually more of ALT, SGPT rise than this one. So usually the ratio of AST to ALT is less than 0.8 and it is more than 1.5 in alcoholic. So usually the steatotic alcoholic liver disease, it will be predominantly AST elevation than ALT. And then when you have increased fibrosis, actually it won't be very helpful also. The people may have SGOT, SGPT normals. Gamma GT not so much elevated, it still is more classical of alcoholic liver disease. Of course, when you have biochemical features of liver failure, you will get a host of other things that I'm not going to enter into detail. Reasonably, you have to rule out hepatitis B, C, and if everything looks very dodgy, maybe autoimmune hepatitis or hemochromatosis. You have to screen, and the first screening method is using some biochemical markers. The most approved, even what the latest ADA 2025 recommendation is using this calculator known as FIB4. So just like how you calculate EGFR, if you ask any senior nephrologist which is the best method of calculating EGFR, Cockcroft-Gold formula, the EPI formula, any good nephrologist will tell you, use whatever formula you want, please calculate creatinine clearance. That is only. So you can use any of this. Why FIB4 is underlined is very easy for parameters: age, AST, ALT, platelets. And it's an algorithm. You can download that onto your desktop or keep it in your phone, or I'll show you a QR code. You can take a snapshot of it, keep it in your phone, just scan it, enter the patient's details, you get the FIB4. It is the most validated and the easiest one. It's not as if it's this one to look at which would be better. Then coming on to, so you take some parameters, you calculate a score to help you target, find out which people. Then you use other markers like quantitative imaging biomarkers. You can do MRI, you can do the vibration control transient elastography. Usually what we do here is the ultrasound elastography and the vibration controlled elastography, and they are more sensitive than the conventional ultrasounds and give you an idea. They have, of course, the diagnostic accuracy is more for MRI elastography, but you can't do that for in everybody. I think JPEF is this time, has asked for doctors, help. They are conducting camps for elastography. So that will give you some idea about the liver stiffness actually. So basically all these elastography, what they do is they assess if the liver is stiff or not. When fibrosis sets in, progresses, the stiffness increases. So when the elastography is a method to assess stiffness, so if the liver is more and more and more stiff, common sense, it won't go back to normal. So lesser the fibrosis, lesser the stiffness, lesser the fibrosis, more chance for itself to resolve on its own. So this is the ADA 2025 diagram and algorithm, and what basically they are telling is that the topic itself is about diabetes and MASLD and the highest risk factors. So the people with the highest risk factor for progression of MASLD into fibrosis, cirrhosis and hepatocellular carcinoma are people with MASLD and having diabetes, prediabetes or obesity with cardiovascular risk plus or minus cardiovascular risk factors. So you look at the age, sex, platelets, AST, ALT, calculate the FIB4 score. If the FIB4 score is greater than 1.3, then the future risk of cirrhosis is high. Ask them to get a elastography done. If the stiffness is high, see there are all gray areas in between, that leave it to the gastroenterologist that you ultimately refer. These are simple that you can do it in your OPD basis and screen for and then get away with it so that your patient gets maximum benefit. So when the value in an elastography is more than 8, you have to refer. They are at a higher risk of developing fibrosis followed by cirrhosis. If the FIB score itself is less than less than 1.3, actually the risk is very low. So you can manage it by controlling diabetes, advising weight reduction and monitoring in between so that they have these risk factors, that is there. So you bring down the risk factors. And if the elastography is less and still the FIB4 score is high, again you can only manage it. There is no need for a specialist referral as such. This is what you see. You can scan the code. So this is a typical example. 50-year-old male comes with these values and a platelet of 150. The platelet is normal. The FIB4 score will be somewhere around 3 points. So this value suggests that you have to get a. So you see, ultrasound abdomen can be done everywhere, but the elastography is a little bit more expensive. So you don't want to subject every patient for an elastography. So this helps. So you can take a snapshot of this one, and it will go to the. You can save it, and this QR code is itself, that's enough for calculating a FIB4 score. So coming to per se the management, what are the lifestyle modifications that ADA recommends? Of course, aim for weight loss. How much weight loss? To reduce steatosis, baseline reduction of at least 5% weight loss. To reverse steatohepatitis, at least 10% weight loss. The physical activity recommendation is minimum of 150 milligram per minute per week of aerobic exercise, and ideally that has been changed by a little bit WHO for weight reduction. Now what WHO says that minimum 150 to at least 300 minutes per week. As much as aerobic exercise as possible, but with at least 3 days in a week, 20 to 30 minutes of resistance training. Resistance training can be weight training, ground exercises, or utilize stretch bands. You can use any of them, but aerobic exercise should be added. But in a person who can do all of this, at least 150 minutes. Don't stop at 150 minutes. 150 means 30 days in 30 minutes per day in a week, at least 5 days, not more than 2 days gap. If we tell 150 minutes per week to a patient, what they will do is, they will do it 45, 3 days in a week and stop it. You can't have more than 2 days break at a stretch. Then what about alcohol intake? Never tell what I tell to your patients, because they will ask you what is this 20 gram, what is this 60 grams and all that, and our Malayalis will take it. Doctor has told me 60 grams per day, maximum limit for a male. So that means 60 into 5, 300 grams. So one Saturday I will take 300 grams for your interest. The 60 gram comes to 90 ml of hard liquor, or one full bottle of 1 to 1.5 bottle of a beer, and somewhere around 300 ml of wine. That is what the... So, it doesn't mean that you can accumulate this and take it at the end of the week. If you are taking it once in a month, party goer or regular, whatever it is, this is the maximum that you can take. But alcohol intake, if you have progressive fibrosis greater than F2, it is not allowed. You are automatically putting your... It's a very simple logic. You have your arm sprained. You don't have to tell your patient, don't lift weight with your left hand in bandage. They automatically understand. So when you have progressive fibrosis, you are putting the treatment putting the patient on treatment with MASLD. It is clear that the patient is not supposed to take alcohol. So I generally don't discuss the amount of alcohol with the patients, because they will quote me to their wife and say, the doctor has advised 1 drink in a day means I can take 5 drinks on Saturday. So the next time I am going to see an angry wife, in today's generation, angry spouse, I should say. So you can't blame it's only the men who drink, women also drink. So be careful, women also drink. Don't think that it's a prerogative of men to drink. Women also drink, so you have to assess the alcohol history from ladies also. Then again, coming back to this weight reduction, just to make sure that you also understand and tell the patient. So when you have at least 5% from the baseline, so suppose a 160 centimeter tall gentleman has a weight of 90 kgs, his ideal body weight should somewhere come between 55 to 60. He is not going to achieve that high weight of 55 to 60 in one go. So because he can't reach there, it's not, you're disheartened that, nothing will happen to me. His weight is 90 kg. If he can reduce 4.5 kg over 3 to 6 months, you can expect resolution of steatohepatitis. If he can reduce 90 to 81 in 6 months, he can expect resolution of fibrosis regression. And if more than 10, 15, 20% weight loss can be achieved, then he can even severe fibrosis regression is seen. So this is the data. We are not speaking about random numbers. We are in good quality studies which have shown that this is the scale of improvement with weight loss, and therefore that is why pharmacotherapy, bariatric surgery is greater the weight loss, you have associated greater improvement. So in severe morbid obesity, bariatric surgery can reverse this. This is prior to the generation of the modern GLP-1 receptor and the combined drugs. So that has, that might change this one. So when you think about treatment of MASLD, you have to think of 2 aspects. Treatment of MASLD, treatment of diabetes that favors MASLD. Actually, there is only one drug that is approved for the treatment of MASLD, and maybe one anti-diabetic drug that can be considered according to the latest data. But all other drugs are about preferential or best drugs when you have diabetes and MASLD2. Basically, you are treating the diabetes with a best choice drug, just like how you treat ASCVD in diabetes. You are looking at some best drugs. There is only one drug, I'll come to that, which is a drug for MASLD. So basically the GLP-1 receptor agonist and pioglitazone are, when somebody comes to you and shows you a folder, our executive friends show you that this reverses that, it is useful for MASLD, you have to understand that what are you looking at. You can have liver enzymes reversal, you can have hepatic steatosis reversal, you can have liver stiffness reversal, you can have MASH reversal, you can have fibrosis progression retardation, you can have fibrosis regression. Just like your 3-point MACE value that helps for ASCVD beneficial drug, FDA recommends you have to tick all the 6 boxes to say that it is an MASLD drug. Rest all the points help you to choose the drug. So as of now, among the drugs which have at least some data on fibrosis regression is tirzepatide and GLP-1 receptor agonist injectable high-dose semaglutide. I'm not going to that. You are going to hear about that from multiple halls and multiple speakers about tirzepatide, and I don't want to bore you with that. But these are the 2 drugs that have some sorts of fibrosis regression. There is possible benefit up to pioglitazone also. Then taking all these factors into consideration, let us look some data that that is in interest for us in our Indian patients. pioglitazone has data on fibrosis, retardation of fibrosis progression, and decreasing the inflammation and steatosis. And you can use it in both with diabetes and without diabetes people. And of course, the Indian child saroglitazole. This is it is a PPAR alpha and gamma agonist, which has got improvement in insulin sensitivity and improvement in plasma lipid profile, and finally it has got anti-inflammatory properties and reversal of SGLT transaminases and of course some amount of steatosis. So the meta-analysis of the data with saroglitazole shows that there is a reduction in ALT, there is a significant improvement in liver stiffness. There was, of course, because it was combined by PPAR agonist, you have HbA1c, triglyceride, and total cholesterol results. So, as of now, there is lot of Indian data, and meta-analysis does show that, and Indian authorities suggest you can use saroglitazole for up to improvement in liver stiffness. That means it has not shown fibrosis regression. It has shown maybe it slows down the progression of fibrosis. This is the only agent as of now which has shown to regress fibrosis or as a treatment of choice for MASLD. Resmetirom, it is an oral liver-directed thyroid hormone receptor beta agonist. This is only FDA approved medicine. It's not available in India. Even in US, it is very, very, very costly. I think some more than 50K for one dose or something like that. I don't think, unless it loses its patency or somebody brings it to India, some other route where they will make a generic that you are going to. This is a classic study, the MASLD-NASH study, which showed that there is NASH resolution with no worsening of fibrosis, significant when you are using this drug. There is fibrosis improvement with no worsening of the activity score and also the cholesterol pattern. So it can regress your fibrosis. So it can be given at any stage. So people were given at the fibrosis stage to F1 to up to F4, and nearly 65% of the people enrolled in the MASLD-NASH study had diabetes also. So with or without diabetes, purely a drug for MASLD. So just a quick summary about what we routinely use in our practice. Having said all gastros also agree with me. Ursodeoxycholic acid has no role in MASLD. We still keep on prescribing it because some patients it reduces the transaminase. Vitamin E, my topic is about MASLD in type 2 diabetes. So there it is a little bit controversial because generally some very rare data about insulin resistance, but generally the data with vitamin E shows that in half of the landmark, good studies, it showed improvement. In half it did not show improvement. So take home is that most of us do use it because there is no much harm seen. Some of your patients might benefit from that. The other obeticholic acid, the adimantone, fenofibrate reduces TG. But direct effect on MASLD is not there. What about statins? Actually, contrary to what many people at the, general practitioners and others believe, there is no contraindication for statin. Actually, statin is still beneficial. Only would be a progressing liver disease where the liver condition is so bad that you don't want to give. Usually in MASLD, what we see is a SGOT, SGPT elevation less than 2 to 3 times the upper limit of normal. In that condition, actually, when the patient has diabetes, you should not stop statin. You have to continue the statin because, as I showed earlier, MASLD causes an increase in the incidence of CVD also. So this was a couple of years back, came as the AAC and the American Association of Steatotic Liver Disease recommendation. You can use pioglitazone and GLP-1 receptor agonists, not as a treatment for MASLD, but for a preferential treatment of diabetes with MASLD. For cardiometabolic advantages, again, SGLT2 inhibitor can also be recommended, but steatohepatitis recommendations is not there. Just 3 more slides, I'm finishing. Then medications, like the other medications, these are not to be used as a treatment for steatohepatitis. This is purely from the viewpoint of controlling diabetes. Vitamin E can be considered, and this is the latest ADA recommendation, ADA 2025 recommendation. individualized weight reduction, cardiovascular risk reduction, and when you have the FIB4 less, a mild, no fibrosis, just MASLD, try to use a obesity pharmacotherapy if the patient has obesity. Even if the patient doesn't have obesity, the moderate weight, actually diabetes pharmacotherapy should include at least GLP-1 receptor agonist or pioglitazone or SGLT2. When you need obese people with F2 to F3 at risk for steatohepatitis, again, obesity pharmacotherapy should be considered. Diabetes, again, the same pioglitazone. You can have MASH pharmacotherapy there, but we have only injectable semaglutide which can be considered there. When compensated cirrhosis occurs, obesity pharmacotherapies are also at risk. Then when decompensated risk, you can use insulin for controlling diabetes. Then just one slide about the FGF21 analog and lanifibranor. These are two new drugs in the phase 2 to 3 trials which have shown to be good for MASLD. And the take-home message is that use anti-diabetic metabolic drugs early before the condition where the patient develops fibrosis, and when fibrosis has set in, the metabolic drugs or obesity pharmacotherapy are not going to be used. You have to use disease-specific agents. So with this, I come to the end of my presentation and will just take a moment to have two conference announcement about the state endocrine meeting to be held on August 10th on Hyatt Regency, Kendocon, and also Providence upcoming Diabetes Dialogues, October 25-26.
Thank you, sir.
Thank you. Thank you.
Thank you, sir, for that wonderful talk on MASLD, which is also an epidemic that is growing with diabetes and obesity. But I somehow feel the due attention and importance is still not given to MASLD, both by patients as well as by the physicians. It's considered as something that is there for everyone. So we get a lot of patients who have been diagnosed of MASLD, but that further risk stratification is not done. The radiologist who does the scan say, you have fatty liver, I too have, everyone have. And similarly, the SGPT elevation, people just look at that and say, do I have fatty liver? If that is normal, they believe they don't have fatty liver. So I think this message, more and more sessions are needed, even for the clinicians, to understand that when fatty liver is diagnosed, MASLD is diagnosed, that risk stratification is very important. Previously, we did not have many treatment options. Now, with this wonderful drugs available to us, to reduce that 10% body weight is now possible. When people go to the diabetologist or gastroenterologist, they are advised to lose this 10% body weight and come back, which was not practical before. So now with therapies available, it's very important to risk stratify the patients early, identify those at risk and give them the appropriate treatment early, which is now feasible. So if there are any questions, we can take it.
Actually, remember that when you have your lean diabetic also predisposes you to MASLD. It's not obese type 2 diabetes. Diabetes is a risk factor of MASLD, and when you have diabetes and obesity, the risk actually proportionally increases. And also, don't think that this 40 or 45 of SGOT, SGPT is a normal. That is a age normal. When you are speaking about MASLD, any value greater than 25 is abnormal in a person with diabetes, whether male or female. Maybe in females a little bit, maybe around 30, but any value above 25, that's what most of the hepatologists take. Any value above 25 in a male with diabetes and obesity means that there is a steatosis happening. Try to calculate for the FIB4 score, and if that is elevated, go for elastography.
Sir, excellent talk. Just a question from my side. Even though we don't have enough molecules to treat MASLD, the only two molecules which we can prescribe for almost most of our patients who can afford these molecules are, one is saroglitazar, which is approved in India only, not US. Second is pioglitazone, which has made a comeback like Karun Nair. But what was the dose used in those patients for was showing evidence in MASLD of pioglitazone?
30 milligram.
Low dose or high dose, sir?
30 milligram.
Okay, sir.
30 milligram. There is absolutely no data with the 7.5 milligram, 5 milligram. But why we use it is because the mechanism of action is the same, and we are concerned about the bladder risk of pioglitazone. The bladder risk of pioglitazone is a cumulative dose. So the logic is if we start very low dose, but the studies which showed benefit of this reversal and all this fibrosis retardation and all that, all used 30 milligram. Started off with 15 and used 30 milligram. Most of our patients using 30 milligram is quite difficult because they will gain weight and edema. So that's a problem with that.
Are saroglitazone and pioglitazone used together?
Sorry?
Can we use both together? A patient on pioglitazone for diabetes, can we give saroglitazone?
We don't have data like that, but having said that, if you are planning to use saroglitazone, that would be better because that has got some more Indian data and rather than the high dose pioglitazone that we got. If you are planning to combine and use, I would suggest use pioglitazone and SGLT2 inhibitor. So that will take care of some of the edema and weight gain of pioglitazone.
Whoever is on pioglitazone, if we plan to give saroglitazone, we can withdraw pioglitazone.
Yeah, that would be the best.
Any more questions from the audience? Yes, sir. Please.
How many percentage of patients go for cirrhosis or
That is a very good question. Actually, only if you take the end data, less than 10% of the whole MASLD go in for the hepatocellular carcinoma or the cirrhosis. But they are much, if you take the people with cirrhosis and hepatocellular carcinoma, the more number of people would have diabetes. So it's like a journey, point A to point E. Most of the people who reached point E have started from A, but not all people who started from A reached E. So that's the point. When you now look at liver transplantation, now we look at the number of cirrhosis, now we look at the number of end-stage liver disease. The number one cause has, in the last 2.5 decades, I wrote the MCQ as the number one cause of cirrhosis as alcoholic liver disease for there was no NEET, that was an entrance at that time. Now I think the new answer for the NEET PG would definitely be MASLD. So that is a change that has happened. That is why we are worried, because the prevalence of MASLD is so huge. So you are speaking about less than 10% means the number, you see, if you are speaking about a disease that has only a prevalence of 10% across worldwide, the number of patients also will be very less. But you are speaking about 1 in 2 in the population of India and the 55% prevalence, then the number of, just like, if you are speaking about 10% of 100 is quite bigger number than 10% of 1000.
any marker?
This is the FIB4 is a marker. So that's why when you have a SGOT, SGPT elevation more than 25, I'm not saying 40 or 45, your liver ultrasound showed a steatotic liver disease, the patient is obese, has diabetes, please check a FIB4 score. It's very easy, it's not a very complicated thing. Age, AST, ALT, platelet, these are the only things that you need. Maybe platelet also you would do.
A diabetic patient with obese comes, FIB4 is high, we send for FIB4 is high, we sent for compression elastography, it showed F3. And we started the diet modification, weight reduction, and after, then he reduced his weight up to 5%. Then after how many months we should repeat the compression elastography?
Elastography, they say around 12 weeks you can have an appreciable change. But FIB4 high and a F3, I would put the I would put the patient in consultation with a specialist also, because we may not exclude all the causes, we don't want to miss something.
There are many centers where it is not compression elastography but fibroscan they are read. So to whom we should send, to a good compression elastography center or?
The compression elastography has got much more robust data, but it is the ultrasound elastography and fibroscan which is more easily available. So in that, when you take the cutoffs, in some patients there will be a gray area that it won't come to the progression. So that will be very less. It's actually a tool in diagnosis. That's all I mean. Whatever it's as I said, getting that done with a high FIB4 is much better. So that you will know that whether some fibrosis or not. Actually, the data is more robust for CT and the best would be MRI, but we don't do
false
that.
Positive, false negative.
False negative, a lot of them is there. Then some coincidental liver disease can vary, so that can cause a little bit of positive. So sometimes, the fibros can give a little bit of false negatives can occur.
I think we can wind up the session due to time constraints. Thank you, sir, for taking all the questions.